Hello everyone, welcome back to Critical Care MD. This is Dr. Vikas Kopurapu. Let me start by wishing you all a very happy new year. In today's lecture, I'm going to be discussing some important publications from the last 12 months that are pertinent to the practice of pulmonary and critical care medicine. Before talking about individual articles, let's briefly talk about the grade system. This stands for Grading of Recommendations, Assessment, Development, and Evaluation. This is a standardized way of assessing the literature. Several respected societies use this grade system of analyzing the literature. It looks at two important aspects of a publication: one, the quality of evidence, and two, the strength of recommendation. Quality of evidence can range from high to very low. It depends on how scientifically sound a study is. Case series and case reports constitute basic forms of evidence, whereas systematic review and meta-analysis constitutes top quality of evidence. Within each type of study, there can be good studies or bad studies. Let's take, for example, randomized control trials. A good randomized control trial is one that is done at multiple centers across nations, double blinded, and include thousands of patients. But sometimes you'll come across randomized control trials which are done at only one institution and include only few patients. So within each tier, the quality of evidence can be upgraded or downgraded depending on how good the study is done. Strength of recommendation depends on the balance between desirable effect and undesirable effect. Ideally, there should be a strong desirable effect with weak or nil undesirable effect, in which case a strong recommendation is made. But if the desirable effect is weak, and especially when there is a signal towards undesirable effect, then a weak recommendation is made. In summary, whether a new study should change our practice or not depends on two factors. One, the quality of the study, shown here along the y-axis, and two, the magnitude or size of the treatment effect, shown here along the x-axis. Professional societies like American Thoracic Society or Society of Critical Care Medicine use the terms like "we recommend" when the quality of study and magnitude of findings are good. They may use terms like "we suggest" or "make a conditional recommendation" when the quality and or magnitude are not the best. With that background, let's first start with updates in critical care medicine. The role of steroids in ARDS used to be controversial, but in the last few years, there have been a number of studies which showed benefit with steroids in ARDS. This led to professional societies like American Thoracic Society and Society of Critical Care Medicine update their guidelines. ATS in early 2024 made a conditional recommendation for use of corticosteroids in patients with ARDS. We'll talk a little more about this conditional recommendation in one of the subsequent slides. There are very few interventions that have been shown to have a mortality benefit in ARDS. First is lung protective ventilation, and second is prone positioning in select patients. So, this new update or evidence showing steroids reducing ARDS mortality is exciting. SCCM also updated its recommendations on steroids in ARDS. Just like ATS, it makes a conditional recommendation for use of steroids in ARDS. A couple of other updates worth noting are: it makes a strong recommendation for use of steroids in severe community acquired bacterial pneumonia. It also makes a conditional recommendation for use of steroids for sepsis and septic shock. There was an excellent review article in JAMA last year on use of steroids in pulmonary infections. It talks about the studies showing mortality benefit with steroids in three kinds of pulmonary infections. First, COVID 19. There was a randomized control trial of more than 6,000 hospitalized patients where use of dexamethasone was associated with lower mortality. It also talks about meta-analysis of 7 randomized trials, including more than 1,500 patients, where use of hydrocortisone was associated with lower 30-day mortality. Finally, it also talks about meta-analysis of 6 randomized trials, which showed improved mortality with low dose steroids in pneumocystis pneumonia. Further, a predefined subgroup analysis of a trial looking at low dose steroids in septic shock showed that patients with community acquired pneumonia had improved mortality when a combination of hydrocortisone and fludrocortisone was used. It also talks about a meta analysis of 8 studies that showed that low dose steroids were associated with mortality benefit in ARDS. Keep in mind that in all these studies, mortality benefit was shown with low dose steroids defined as 400 milligrams or less of hydrocortisone per day, which is equivalent to 80 milligrams of methylprednisolone or solumedrol per day. If you want more information about this article, just notice the PubMed ID provided on the screen and enter it in the search box of PubMed website. I will provide a link to that website in the description. You will find the abstract of the article, but if you want the full text, you can also find the links on the right hand side of the screen. You can use this method to find full text of any article that is discussed in this lecture. The recommendation for steroids in ARDS is a conditional recommendation. It is not a strong recommendation, and certain caveats must be kept in mind. Most of the trials excluded immunocompromised patients. Based on some observational studies, there is a signal for harm in influenza pneumonia, and TB and fungal pneumonias are not well studied. Benefit is not well established when steroids are started late in the course. And whenever used, steroids must be kept to as short duration as possible. It is also worth noting that the European Society of Intensive Care Medicine did not make any comment on use of steroids in ARDS. Previously, the ESICM and ATS used to make joint statements, but now ESICM has not made any comment and is probably waiting for more evidence before making a statement on steroids in ARDS. ATS also made some conditional recommendations or suggestions based on low certainty of evidence. I don't see these as practice changing, but I will mention them for the sake of completion. It recommends or suggests VV ECMO in select patients with severe ARDS. It suggests neuromuscular blockade in patients with severe ARDS early in the course of their illness. It also suggests using higher PEEP as opposed to lower PEEP in patients with moderate to severe ARDS. It is worth noting that European Society of Intensive Care Medicine felt that the evidence was not enough to recommend for or against any PEEP titration strategy. ATS did quote a meta-analysis of 18 randomized trials which showed higher PEEP was associated with lower mortality, but overall the quality of evidence was not that great. Here are 2 examples of PEEP titration based on low PEEP and high PEEP. Non-invasive ventilation reduces mortality and intubation rates in acute exacerbation of COPD and is considered the standard of care, but the optimal settings for NIV are unclear. This randomized controlled trial in China compared high intensity versus low intensity settings for NIV in patients with COPD exacerbation. 300 patients with COPD exacerbation who were still in hypercapnic respiratory failure after 6 hours of low intensity non invasive ventilation were randomized to either high intensity NIV, where IPAP was adjusted to target a tidal volume of 10 to 15 ml per kilogram, or a low intensity NIV, where IPAP was adjusted for a tidal volume of 6 to 10 ml per kilogram. This is what they found. Patients in the high intensity arm were much less likely to fail compared to patients in the low intensity arm. However, the intubation rates were the same between the groups, and the reason for that is patients who failed the low intensity NIV, instead of going straight to intubation, they were switched to high intensity NIV, and the ultimate need for intubation significantly came down in that arm as well. NIV intolerance and abdominal distension, as can be expected, were seen more commonly with the high intensity settings. So, what do we make of these findings? Should we put all of our patients on high intensity NIV? I am not so sure. While one could argue that high intensity is associated with less risk for failure and potentially less work of breathing for the patient, arguments in favor for low intensity would be better tolerance, because if the patient just keeps pulling off the mask because they don't tolerate it, it's not serving the purpose. While less important in COPD, tidal volumes are important when it comes to lung protection. Especially in ARDS, excess tidal volumes are associated with alveolar stretch and lung injury. So that's something to keep in mind. And finally, as long as we pay close attention to patients who are failing and switch them to higher support in a timely manner, ultimate need for intubation is not really different between the arms. So we really need to pick settings based on individual patient needs. Last but not least, I would like to see these kind of results replicated in further studies in different settings or different countries before making changes to usual practice. Severe hypoxemia is a serious complication of intubation, and pre-oxygenation, which is a step before intubation, involves providing high levels of oxygen support to the patient so that the risk for hypoxemia is reduced during intubation. Traditionally, pre-oxygenation is provided via face mask, but in this randomized controlled trial, they compared pre-oxygenation with face mask versus non-invasive ventilation. About 1,300 patients in 24 EDs and ICUs across US were randomized to receive pre-oxygenation via face mask or NIV. What they found was hypoxemia, defined as SpO2 less than 85%, occurred in 9.1% in the NIV group compared to 18.5% in the oxygen mask group. This result was statistically significant. The risk of cardiac arrest was much lower in the NIV group versus oxygen mask group. Aspiration was also less common in the NIV group. Based on this study, we should really be pre-oxygenating critically ill patients with NIV as opposed to face mask. Video laryngoscopes have been used for intubation for several years, but studies looking at their advantages compared to direct laryngoscopy have yielded mixed results. In this recent systematic review and meta-analysis, they looked at direct laryngoscopy versus video laryngoscopy for intubations. Over 4,500 critically ill patients from 20 trials were included. What they found was the first pass success rate was better with video laryngoscopy compared to direct laryngoscopy. Video laryngoscopy was also associated with other favorable outcomes like decrease in esophageal intubations, dental injuries, and aspiration events. More and more recent literature is favoring video laryngoscopy over direct laryngoscopy. Intubation can be associated with some serious consequences like severe hypoxemia, hemodynamic instability, and cardiac arrest. If the patient has difficult airway, for example, a narrow mouth opening or altered laryngeal anatomy, say for example from a prior radiation, the risk for this complication is much higher. So it is very important to have a proper plan when difficult airway is anticipated. This randomized control trial shed some light on what would be a good plan for anticipated difficult airway. It included 182 patients with anticipated difficult airway. These patients were scheduled to undergo ENT or oral/maxillofacial surgery. What it found was D blade, or the hyperangulated blade, was not only associated with improved visualization of the glottis, but also much better first pass intubation success rate and overall lower rate of failed intubation. So it is important to use a D blade for anticipated difficult airways, or at least have it immediately available as a backup for difficult cases. The role of Bougie for intubations has remained controversial. In 2021, there was a large randomized controlled trial which showed no benefit with use of Bougie. I happen to be one of the authors of that article. But there is a more recent systematic review and meta analysis which sheds more light on the role of Bougie. This study included over 9,000 patients from over 100 studies and found that Bougie was in fact associated with improved first pass success rate. The best benefit from Bougie was noted in patients who had difficult views of the glottis. Though this is an interesting study, it is probably not going to be practice changing, and it's a good example where the grade system should be applied. Though the study was a systematic review and meta analysis which sits at the top of the evidence pyramid, the overall impact is still low because the findings from multiple randomized control trials, they were pretty inconsistent. If pretty much all of the studies showed benefit, then the confidence would be higher, but some studies showed no benefit and some studies showed benefit, so the confidence goes down. Further, the magnitude of effect was also not that great. The risk ratio was just 1.1. So for these reasons, this study is probably not going to be practice changing. However, one important take home message from this study is that Bougie use had a much higher impact when there was a difficult view of the glottis. So I will continue to make sure that Bougie is available as a backup for my intubations in the ICU. Prolonged mechanical ventilation is associated with several adverse effects like barotrauma, volutrauma, ventilator associated pneumonia, and so on. Every effort must be made to wean patients from mechanical ventilation as early as possible. Traditionally, this is done via pressure support trials, but there is an alternate mode of spontaneous breathing trial called a TPS trial, where the endotracheal tube is disconnected from the ventilator and connected to high flow oxygen. This randomized control trial, which was published in JAMA, compared two things. One, the method of spontaneous breathing trial, which is TPs versus pressure support trials. Second was the frequency of spontaneous breathing trial. About 800 patients who were on, let's say, low to moderate amount of PEEP and FiO2 support were randomized to TPs versus pressure support mode of spontaneous breathing trial. Using a 2 by 2 factorial design, they further tested once a day screening versus more frequent screening with spontaneous breathing trials. Here's what they found. The shortest time to extubation was found with once a day screening with pressure support trials, and the longest time to extubation, which is about 3.9 days here, was seen with pressure support trials where patients were screened more often than once a day. While this is an interesting finding, the difference was not statistically significant. In other words, more than once a day screening did not lead to faster extubations. Earlier in 2024, there was a systematic review and meta analysis which included more than 6,700 patients from 40 trials. This study concluded that patients who underwent pressure support trials were 7% more likely to be successfully extubated compared to TPs. Based on these studies, it would be prudent to continue using pressure support trials and screen patients once a day to assess readiness for extubation. Let's switch gears to sepsis. This systematic review and meta analysis published in JAMA compared continuous versus intermittent infusion of beta lactam antibiotics for patients with septic shock. More than 9,000 critically ill patients with sepsis and septic shock were included. Here are the key findings. Mortality was lower with continuous infusions. There was also reduced risk of ICU mortality and overall increase in clinical cure rate with continuous infusions. Recent data is supporting continuous infusions over intermittent antibiotics. So we may see more and more institutions replace their intermittent bolus dosing with continuous antibiotic infusions to achieve better outcomes. This randomized control trial compared 7 days versus 14 days treatment for hospitalized patients with bacteremia. About 3,600 patients were included, over half of whom were in the ICU. The key finding was that the 90-day mortality was not different between 7 days versus 14 days. So, this study supports shorter duration of antibiotics for bacteremic patients. It is important to note that certain patients were excluded, like patients who were severely immunocompromised, patients who had septic foci requiring prolonged treatment like infective endocarditis, osteomyelitis, etc. Staph aureus bacteremic patients were excluded, and patients who had single cultures which were considered contaminants were also excluded from the study. Moving on to nutrition, the optimal nutrition strategy, especially the strategy for protein supplementation in critically ill patients, is unclear. Some people may argue that augmenting protein supplementation may help with muscle wasting in critically ill patients. This trial precisely tried to evaluate that hypothesis. About 900 patients receiving mechanical ventilation were randomized to either 2 grams per kilograms per day or 1.3 grams per kilograms per day of protein supplementation via enteral nutrition. The primary outcome was health score as assessed by EQ5D5L score. What they found was patients who received higher protein actually had slightly lower score that was statistically significant, meaning they actually did slightly worse than patients who received lower protein supplementation. As expected, GI intolerance was also higher in patients who received high protein. Mortality was not different between the groups. It would be worth reviewing an older article as well at this point. In this randomized controlled trial, about 1,300 patients undergoing mechanical ventilation who were at nutritionally high risk were randomized to either high dose or low dose protein. Primary outcome was time to discharge alive from the hospital up to 60 days after admission, and secondary outcome was 60-day mortality. There was no difference in either of these outcomes. Further, a subgroup analysis showed that high protein was particularly harmful in patients with AKI and in patients who had high organ failure scores. A post hoc analysis showed no benefit even in patients who had pre existing malnutrition. So, it may be time to review the recommendations from American and European societies for nutrition. Aspen recommends 1.2 to 2 grams per kilograms per day, whereas European guidelines recommend at least 1.3. So it would be important to try and use the lower end of this recommended spectrum. Moving on to Neuro-ICU, the ideal transfusion threshold for patients with acute brain injury is unclear. A couple of randomized controlled trials shed some light in this area. In the first randomized controlled trial, 742 patients with moderate to severe traumatic brain injury were randomized to either transfusion threshold of 10 or 7 grams per deciliter. Primary outcome measured was an unfavorable neurological outcome at 6 months. What they found was 68.4% in the liberal group, meaning threshold of 10 grams per deciliter, had an unfavorable neurologic outcome compared to 73.5. While this difference was not statistically significant, it did favor the liberal threshold. Incidence of ARDS was more in the liberal threshold, as can be expected. Excess transfusions are associated with the risk of transfusion associated acute lung injury. Mortality and venous thromboembolism rates were not different between the groups. The second trial was published in JAMA. 820 patients with either traumatic brain injury or intracranial hemorrhage, both of these were called acute brain injury patients, were randomized to either 7 grams per deciliter or 9 grams per deciliter transfusion thresholds. Again, the unfavorable neurologic outcomes at 6 months favored the liberal group, meaning 9 grams per deciliter. Same with the cerebral ischemic events. The outcomes favored 9 grams per deciliter over 7 grams per deciliter. These differences were statistically significant as well. Based on these newer studies, targeting a hemoglobin threshold of 9 grams per deciliter may be reasonable in patients with acute brain injury. Mechanical thrombectomy has revolutionized the care for patients with acute ischemic strokes. However, their benefit in patients with largest strokes remains unclear because patients with very large ischemic strokes were excluded from the initial trials due to the theoretic risk for complications like bleeding and edema after reperfusing a large area of ischemic brain tissue. This randomized controlled trial done in Europe attempts to clear that doubt. 333 patients with proximal anterior occlusion and a large infarct were randomized to usual medical care versus mechanical thrombectomy. What they found was mortality in the thrombectomy arm was much lower, and even the functional outcomes favored the mechanical thrombectomy arm. In fact, this trial was terminated early because of an interim analysis which strongly suggested benefits from thrombectomy. However, some risks were also noted in the mechanical thrombectomy arm. 7% of the patients experienced complications related to the procedure, mostly issues at the vascular access site. And there was also a higher incidence of symptomatic intracranial hemorrhage in the mechanical thrombectomy arm. Regardless, the benefits outweigh the risks, and we will continue to see mechanical thrombectomy make huge impact in stroke care. Over the last several years, mechanical circulatory support, mainly in the form of Impella, has been widely employed in the care of patients with cardiogenic shock. However, the evidence to back up this practice was lacking until this trial came out. 355 patients with cardiogenic shock in setting of ST elevation myocardial infarction were randomized to Impella versus usual care. Primary outcome was mortality at 180 days. This strongly favored Impella group compared to the standard care group. Unfortunately, the adverse effects were also higher in the Impella group, particularly acute kidney injury needing renal replacement therapy was higher. One good news though is the AKI seemed to be reversible. After 6 months of follow up, none of the surviving patients continued to require dialysis. Now let's move on to updates in pulmonary medicine. A short-acting beta agonist slash SABA like albuterol has been the standard rescue inhaler for asthma for a long time. But several recent studies have challenged this and showed that a combination of inhaled steroids and beta agonist leads to better outcomes compared to a SABA alone. A recently published systematic review and meta-analysis further clarifies this issue. A meta analysis of 13 trials, including more than 19,000 patients, has shown that a combination of inhaled corticosteroids slash ICS and formoterol was associated with reduced risk of asthma exacerbations compared to SABA alone. The specialty of formoterol is that it has a fast onset of action. It is not necessarily a short acting agent, but it is a fast acting agent. Another meta analysis of 4 trials, where almost 5,000 patients were included, showed that a combination of inhaled corticosteroids and a SABA like albuterol led to decreased risk of asthma exacerbations compared to albuterol alone. With this new evidence, our patients with asthma should not be just on albuterol for rescue. They should have a combination of inhaled corticosteroid and a fast acting or a short acting beta agonist. As some chronic lung conditions like COPD and pulmonary fibrosis evolve, several patients end up on home oxygen. Traditionally, home oxygen has been recommended to be worn continuously 24 hours a day. A recently published randomized trial challenges this hypothesis. 241 patients with severe hypoxemia, defined as SpO2 of less than 88%, were randomized to 15 hours versus 24 hours a day of supplemental oxygen. 70% of these patients had COPD, and majority of the remaining patients had pulmonary fibrosis. After 1 year, there were no significant differences in any of the measured outcomes, including mortality, symptoms, exacerbations, quality of life, and such. Based on this study, should we ask all our patients on home oxygen to limit their use to simply 15 hours a day? I'm not so sure. We have to balance the risks and benefits. argument in favor of 15 hours would be better acceptance. Having to carry oxygen cylinders slows down our patients, and it can also lead to social embarrassment, and it may further limit their mobility. However, argument in favor of 24 hours would be just that the study was not long enough. The patients were followed simply for a year. Majority of the patients with COPD, even when they're on home oxygen, tend to live longer than 1 year. So if these patients were followed for 2 years, or let's say 5 years, maybe we would have started to see a difference in mortality. So recommendation must be based on individual patient needs. COPD is one of the commonest chronic lung diseases, and the morbidity burden of COPD disproportionately falls on patients who keep having frequent exacerbations. Sometimes these patients keep having exacerbations despite being on maximal or the so-called triple inhaler therapy. A biologic agent called Dupixent or Dupilumab gives hope for such patients. 935 patients with frequent exacerbations of COPD despite being on triple inhale therapy and having elevated blood eosinophil count of more than 300 cells per microliter were randomized to Dupilumab versus placebo. Frequent exacerbations were defined as two or more episodes needing outpatient treatment or one or more episode needing inpatient treatment. Dupilumab is a biologic agent that blocks IL-4 and IL-13 receptors, which are important mediators of eosinophil-mediated type 2 inflammation. Dupilumab was associated with 34% reduction in moderate to severe COPD exacerbations. Not only that, but lung function as assessed with FEV1 was better preserved over time with Dupilumab. However, there were no significant differences in symptoms or quality of life. It would have been nice to see an improvement in this area as well, but for those patients with frequent exacerbations, this is a very important update. Persistent air leak can be a frustrating problem to deal with. When we have patients who present with secondary pneumothorax, meaning pneumothorax occurring in setting of underlying lung disease like cystic lung disease or emphysematous bullae, the usual sequence of management is we place a chest tube, we put it on suction, eventually we put it on water seal and eventually clamp the tube, and if the pneumothorax has resolved and is not coming back, then the chest tube is removed. However, this sequence can be broken at any time if there is persistent air leak. Let's say we put chest tube on water seal and the next day chest x-ray shows pneumothorax is coming back, then we can't proceed with clamping trial. In such cases, usually we consult thoracic surgery for consideration of pleural disease. But once in a while, we'll have a patient who is too high risk for surgery, or sometimes patients undergo surgery but still have pneumothorax. This can be a very frustrating problem to deal with, and there is not much evidence or literature to guide management in this setting. A couple of recently published articles provide some guidance in this area. In mid 2024, the European Respiratory Society, the European Association of Cardiothoracic Surgery, and European Society of Thoracic Surgeons issued a joint statement where they made a conditional recommendation for autologous blood patch in these situations. Autologous blood patch means patient's own blood is infused into the thoracic cavity and can help with pleural disease. Shortly after the joint statement was issued, a case series on endobronchial valves was published. 66 cases of endobronchial valve therapy were reviewed. Majority of the patients had COPD or lung cancer as the underlying diagnosis. The median time between pneumothorax and placement of the valve was around 25 days, and the range included up to 54 days. Just goes on to say how complicated situation this is. They showed that in about 61% of the patients, the air leak resolved within 30 days of endobronchial valve placement. So overall, the issue of persistent air leak in secondary spontaneous pneumothorax remains a complex situation, and ideal management is not clear, but these therapies hold some promise. Peripheral pulmonary nodules are the nodules that are located within the outer third of lung parenchyma, and the diagnosis or biopsy of these nodules can be challenging. A recently published systematic review and meta analysis compares available biopsy modalities for these nodules. The review included 363 studies. The main findings were the CT guided transthoracic biopsy, which is done by interventional radiology, had highest diagnostic yield, whereas robot assisted bronchoscopy wasn't too far behind. The complication rate was better for robot assisted bronchoscopy compared to percutaneous CT guided biopsy. An additional advantage of robot assisted bronchoscopy is that staging via EBUS guided endobronchial ultrasound guided biopsy of mediastinal lymph nodes can be done during the same procedure. So, given the better safety profile and comparable success rate, robotic bronchoscopy is likely going to replace percutaneous IR biopsy as the initial method of choice for biopsying peripheral pulmonary nodules. The last article I will discuss is this systematic review and meta-analysis looking at effect of CPAP treatment on pregnancy-related complications. 6 studies, including more than 800 patients, were included in this meta-analysis. The main finding was use of CPAP led to decreased risk of gestational hypertension and preeclampsia in pregnant patients with OSA, and this benefit was independent of age and body mass index. Based on these results, we should counsel pregnant patients to wear CPAP not only because it helps with symptoms of OSA, but also because it reduces the hypertension related gestational complications. That concludes today's discussion. I hope you found this video helpful. If you did, please support my channel by clicking on the like and subscribe buttons. Also, share it with someone who you think will benefit from this lecture. Finally, I would love to hear your thoughts. Is there any part of this video you found particularly helpful? Is there anything I could have added to make this video more useful to you? And what topics would you like to see me discuss in the future? Do leave a comment and I will see you in the next video.